The topic is management of neck swelling in pediatric patients. You know, the neck is divided into two triangles, anterior and posterior, by sternocleidomastoid. So this is the anterior triangle, anterior to sternomastoid, and posterior to sternomastoid is the posterior triangle. Now the anterior triangle of the neck, this is the anterior triangle, this is the hyoid bone, and this whole of it is the anterior triangle. This is bounded by the anterior border of the sternomastoid. This is the midline, and this is the inferior margin of the mandible. Now, this triangle is further subdivided into four triangles by the anterior belly of digastric muscle, posterior belly of digastric muscle, and the superior belly of omohyoid muscles. So the four triangles are submental triangle, submandibular triangle, this is the carotid triangle, and the muscular triangle. The posterior triangle boundaries are the posterior border of the sternomastoid muscle, anterior border of the trapezius muscle, the middle 1/3 of the clavicle, and the posterior triangle is subdivided by this inferior belly of omohyoid into two triangles, the occipital triangle and the supraclavicular triangle. So it matters because location of the lump within the neck can sometimes be useful in narrowing the differential diagnosis, particularly when combined with other clinical findings and investigation results. And in exam, question regarding the midline swellings is asked, and sometimes what are the lateral swellings and what are in different triangles of the neck. The submental triangle is the only unpaired triangle which is bounded by the hyoid muscle and on both the sides by the anterior belly of the digastric muscle. So submental triangle is the only unpaired triangle in the neck, while all the others like submandibular, carotid, muscular, and the posterior triangles, they are in pairs. Now the neck swelling can be further subdivided into developmental, inflammatory or reactive, and neoplastic. And depending upon this location, it may be placed in any of the triangles. The developmental triangles, the developmental swellings are thyroglossal duct cyst, dermoid cyst, branchial cleft cyst, and vascular and lymphatic malformations. And these vascular and lymphatic malformations, they become a huge swelling later on. Then in inflammatory and reactive, they are reactive lymphadenitis, and then in neoplastic, it may be malignant lymphadenopathy or the benign connective tissue. Branchial cyst, it arises from embryological remnants of the second branchial cleft in the neck. The solitary smooth cyst is most often located in the anterior triangle. Usually it's painless, but may be painful during acute infection, and branchial cyst may also get enlarged, and it's been reported that it becomes a huge swelling and may impinge upon the airways. Then thyroglossal cyst, it's the persistence of the thyroglossal cyst duct by which the thyroid gland descends during the embryological development to its final position in the front of the neck. The tongue is attached to the thyroglossal duct, which is why thyroglossal cyst rises during tongue protrusion, and it's a midline swelling. Dermoid cyst, it formed along the lines of the embryological fusion and is presented as a painless swelling that do not move with tongue protrusion. Lymph node swellings, it may be solitary and they may be multiple and associated with underlying infection or malignancy, and with infection they may present as retropharyngeal or parapharyngeal neck masses, and as abscess deep neck abscess. Ludwig's angina, it's a rapidly progressive, severe soft tissue infection of the neck and the floor of the mouth. And this is like this, and sometimes it covers whole of the neck from one side to the other, and it creates a bull neck like picture. So early recognition and prompt management are very important to avoid life-threatening acute airway obstruction. Then comes cystic hygroma. It's a congenital lymphatic lesion, and it's the result of a failure of the lymphatics to connect to the venous system. So more of the lymphatic pockets are gathered around, but they are not being drained, and with the growth, they become so much enlarged that they may compromise the airway. So they can arise anywhere, but typically they develop in the left posterior triangle of the neck. Then tumor neck. The neoplasm of the head and neck are approximately 5% of all childhood malignancies, and they cause severe hemodynamic effects due to the proximity of great blood vessels and decompression, which is induced by surgical removal. So one has to be very careful about the blood loss. So neck swellings may present in elective surgery or emergency surgery. It's not necessary that the patient who is coming for elective surgery, if by chance there is hemorrhage or infection inside that cyst, then that benign sort of appearing cyst may become so aggressive that it compromises the airway. While talking about these Ludwig's angina and deep neck abscesses, they come in emergency. No doubt they are drainage procedures, they are very short procedures, but endotracheal intubation is a must, because you never know how the baby behaves when this is drained. One may say that because the pressure is now removed, so there won't be any problem regarding the airway, but it's not like that. Edema is still there. Soft tissue is around the larynx, glottis. Babies have very narrow airways, so trachea is very compliant. There's so many things which may make them prone for airway problems. So one has to be very careful about this, that no doubt it's a very short procedure, but all the precautions have to be taken care of. Now, preoperative evaluation, particularly I'll be going particularly for the neck swelling. Signs, symptoms of airway compression, respiratory distress, cough, stridor, tachypnea, dysphagia, dyspnea. Then size and extent of the neck mass to detect the potential for airway compromise and to avoid soft tissue trauma during intubation with consequent acute airway obstruction. So even if it's a small swelling or it's a big swelling, you have to do the local examination of the swelling, starting from the placement, where's the size, in which compartment it's located, and the involvement of that neck mass, then the trans-illumination, everything related to swelling, tender or it's non-tender, everything related to swelling. I'm not going into detail about that. So you have to see to it. Then genetic abnormalities are mostly associated up to 75% with the cystic hygroma patients. Then Noonan and Turner syndromes, as Dr. Apurva has already talked about these syndrome. Now, in Noonan and Turner, cardiac problems are there, high arch palate is there, there's a short neck. In Noonan, it's mental retardation is maybe there. So in Down syndrome, mentally retarded, but atlantoaxial instability is there. Klinefelter, he's shown a picture already of that, the fused cervical vertebrae. So just imagine a huge swelling along with these problems with the cervical spine. It makes a chaos. So one has to be prepared, because all of these are anticipated difficult airways. Now, airway patency and stability, for difficult airway has to be judged, and inspiratory stridor suggests supraglottic obstruction, while expiratory stridor is associated with subglottic or intrathoracic obstruction. Cervical masses may be adherent to, or they can cause compression of the great vessels, or they extend into the mediastinum. So assess the respiratory status in different positions to assess for compression of the mediastinal structures. Then evidence of congenital cardiac disease may be there, and surgical consultation for concerns regarding neck surgery with respect to timing, duration, blood loss, and post-operative support has to be there. Regarding investigation, if it's a very small lesion, then these babies are almost healthy, so not much of the investigations are required, but otherwise, complete blood count, platelet count, INR, serum urea, creatinine, electrolytes, everything, including 2D echo if congenital cardiac anomalies are there. And the most important part is the radiological investigations: ultrasonography, chest X-ray, CT scan, and MRI. Ultrasonography is very important if we do it beforehand, because if suppose there is compression of the trachea with this swelling, so with USG we can make it out beforehand whether the this compression would be relieved if the swelling is shifted or lifted up, which helps in performing the intubation with ease. So all these radiological investigations regarding size, position, extent of involvement, position of the tongue, supraglottic and the infraglottic structures also are included relative to the mass and vascularity of the lesion. Pre-medication usually not necessary. So 6 months, but neonates and small babies till 6 months, they are having prepondering parasympathetic tone, so atropine has to be included. Otherwise also it's a neck surgery, so vagus is involved, so it's better to give atropine. Now, most common route used is for other investigation.
The molecule in the plasma must
oral is slow onset and baby may spit it out. IM is painful, rectal is uncomfortable, nasal is irritating. There is a great variation in the recommendations for pre-medication of pediatric patients, but in patients with anticipated airway compromise, pre-medication is avoided. Otherwise, oral midas 30 minutes prior to procedure may be given. Monitoring, basic monitors for small swelling, but for large swelling, all these monitors along with the end-tidal volatile agent is available, NMT if available, and core temperature is, of course, it's very important. Temperature can be maintained by warm OT, IV fluids, irrigating solutions, and towels wrapped around head and extremities, and heated blankets. Flexible fiber optic bronchoscope is the gold standard of difficult airway management in pediatric patients. But sometimes if you anticipate a difficult intubation in adults, we do the awake fiber optic intubation, which may be aided up with the IV induction also, IV sedation. But in pediatric patients, we cannot do awake intubation. A few reports have been available, but that is a totally different thing. But we want something evidence-based. So that means in pediatric patients, inhalational induction has to be there along with the topicalization with the local anesthetic, which may be in the form of nebulization or in the form of aerosolization. It has to be there. So inhalational has to be a support for pediatric patients because they are not cooperative. They don't understand what's going on. So this thing is the difference. Then video laryngoscopes have a very good, position in difficult airway. But what happens that sometimes in the presence of parapharyngeal masses, fiber optic aided fiber optic bronchoscopic aided with the direct laryngoscopy may be helpful for intubations. And video laryngoscopes may be helpful when chosen according to the anatomy and site of the mass. That means like glidoscope. Glidoscope should be used with caution in parapharyngeal masses because it goes in midline. CMAC may be a better option for left-sided parapharyngeal masses because CMAC with this Macintosh plate, you can shift it and it goes so smoothly inside that and glottis is visualized. So it all depends upon the anesthesiologist to judge the picture and anticipate the problems and choose the device accordingly, whether it should be a fiber optic, how it's to be performed. It has to be video laryngoscopy, or simply, yes, DL can be done. We can proceed with that. So it's up to them. But yes, expertise is very important. Ultrasound guided intubation is now being done. So ultrasound has recently been used to visualize airway structures and endotracheal intubation in real time in pediatric patients. So it's a boon. It may be considered during difficult intubation when there is a trained operator, but insufficient evidence to recommend this method routinely. And point of care ultrasound focus is coming into place, and maybe you never know, in future it would also have a place in all those algorithms. So they are the things which are so beneficial, so much beneficial for proceeding with the management of difficult airways, whether it's anticipated or it's unanticipated. I'll talk about anticipated difficult airway before, because this is our scenario. So we may have a problem with the difficulty in bag mask ventilation. Then what one has to do, insert an oropharyngeal airway or optimize patient's position, use two hands, provide CPAP, adequate depth of anesthesia, because otherwise laryngospasm may get precipitated, and we want to avoid that. And you have to see whether there is gastric distension or not. If it is there because of that IPPR with mask, then one has to desufflate this and proceed, because the gastric distension, it splints up the diaphragm. Now, if difficult mask ventilation persists, then supraglottic airway device has to be inserted. And if there is adequate ventilation with supraglottic airway device, the surgery can be continued after discussion with the surgeon. But if endotracheal intubation is required for that particular procedure, then tracheal intubation is done with fiber optic bronchoscope through the supraglottic airway device as conduit. And if it's not successful, then it's better to postpone the surgery. If there is inadequate ventilation with SAD and SpO2 is not rapidly declining, consider waking the patient up. If it may be bag mask ventilation easy, but there is difficult ventilation. If difficult direct laryngoscopy is there, then switch over to indirect technique. Choose fiber optic or video laryngoscope, but limit the number of unsuccessful attempts, because multiple attempts, they increase the risk of serious complications. Consider using airway adjuncts. Bougie may be tried, and even ultrasound can be taken care of. Then tracheal intubation, if unsuccessful, place SAD, and that cycle previously discussed can be repeated.
Madam, voice disconnected. Hello. मैडम आपका म्यूट हो गया, प्लीज को अनम्यूट करिए. अनीता मैम, आपका अनम्यूट करना पड़ेगा. म्यूट हो गया आपका, एक बार अनम्यूट करिए. Yes. It's okay.
Hello.
Okay. हाँ बोलिए आवाज आ रही है.
Okay, right. So DAS and APA guidelines are for unanticipated difficult mask ventilation and difficult tracheal intubation. Now, children up to 1 to 8 years, failed bag mask ventilation, then insert shoulder roll or change the position. Not more than 3 attempts for supraglottic airway device are to be taken. And if the airway is not good, saturation is more than 80%, wake up the patient. If saturation is less, then if you can try intubating the patient with paralysis, with relaxant. It's been described because this is an unanticipated difficult mask ventilation and difficult tracheal intubation. And even if that fails, then the situation lands up in CICV. Can't intubate, can't ventilate. But if bag mask ventilation is good, difficult DL, not more than 4 attempts, straight blade or indirect video laryngoscopy. If it's failed intubation, supraglottic air device, 3 attempts, and 1 attempt, only 1 attempt of fiber optic intubation through SAD is advisable. And failed oxygenation, less than 90%, it's better to wake up the patient. Or can't intubate, can't ventilation situation, then surgical access is advisable. All India Difficult Airway Association has also come up with pediatric guidelines for unanticipated difficult tracheal intubation, and this is applicable from 1 to 12 years. Optimum technique similar to the ones like DAS, but it's shoulder roll advisable in less than 6 months. Maximum number of attempts at intubation is 2. And if SpO2 is more than 95%, adequate oxygenation should be there, depth of anesthesia should be proper, and optimal equipment should be there, positioning, external laryngeal manipulation should be done, and one should go ahead. But when intubation fails, so supraglottic airway device with 2nd generation is preferable. In IDA guidelines, 2 attempts are allowed, and then SAD can act as a conduit for fiber optic intubation. And if SAD insertion fails, 1 final attempt at mask ventilation should be tried after ensuring neuromuscular blockade. Optimal technique for mask ventilation is provided. Decompression of stomach is done. But if mask ventilation is still, if it is successful, if it's successful, even then the patient should be woken up. If ventilation is still not possible, then emergency surgical airway access is to be done. So a large neck swelling may result in deviation of the trachea, and an emergency surgical airway would be uncertain because of large swelling. So it's always better that when we were discussing about the radiological investigations, it was better that you under USG just see to it where the cricothyroid membrane is, whether surgical access can be done or not. These are the things which are pre-planned in anticipated difficult airway. So crucial points in the management of a difficult airway, especially in infants, is help from senior colleagues, surgical teamwork, no prestige issues should be there. The avoidance of muscle relaxant, so big no-no for muscle relaxant, and use of inhalational anesthesia is advisable. Knowing when to abandon the procedure to avoid adverse events is the foremost important point, which has to be taken care of. So anesthetic considerations, emergency airway card should be ready, IV line should be secured, atropine should be given, and depending upon the circumstances, what the anesthesiologist want to go ahead with, high fiber optic, video laryngoscope, or SAD, whatever it is, or direct laryngoscopy and intubation. So mask induction with sevoflurane, gently assist ventilation as the plane of anesthesia deepens, perform laryngoscopy and endotracheal intubation. And once airway is secured, neuromuscular blockade with rocuronium, vacuronium, or atracurium, an endotracheal tube must be secured carefully. Now, Prevent accidental extubation and endobronchial intubation during surgeon's intraoral exam and extensive cervical manipulation. Avoid tension on endotracheal tube by circuit tubings and reverse the neuromuscular blockade once the surgery is over and extubate the baby when fully awake. Regarding fluid therapy, we have already discussed this in detail. Holiday cigar formula is used in neonates because 4 to 8 ml per kg glucose for brain development is required, and they are having limited glycogen reserve. So they are more susceptible to hypoglycemia. So 1 to 2% of dextrose solution is given. Replacement therapy for intraoperative losses, isotonic solutions and colloids or blood. Now, maximum allowable blood loss we have already discussed as by Dr. Apurva. And if the MABL is less than 1/3, so balanced solution are the one which come into picture, and the ratio of balanced solution with volume of blood loss is 3:1. If it's more than 1/3 MABL, then colloids come into picture with a ratio of 1:1. And if it's more than 1 MABL, then blood transfusion comes into picture. Now, intraoperative complications are dislodgement of endotracheal tube, loss of airway, laryngospasm, bronchospasm, and hemorrhage. Regarding pain management, acetaminophen, fentanyl, infiltration of local anesthetic at incision site, and dexmedetomidine in those patients who are having very small swellings, where this dexim may be given, that it helps in suppressing this emergence delirium. Post-operatively, it's a small lesion, then extubated in the OR. But if it's an extensive lesion, extubation is delayed and the baby is shifted to ICU for extubation after the airway edema subsides and may take 24 to 72 hours. Adequate analgesia is established, and IV fluids are half of holiday cigar to 1.5 in the first 12 hours due to ADH, and resumed to normal maintenance after checking the electrolytes. Post-op complications, subglottic edema, hematoma, upper airway obstruction by the edema related to tumor resection. Then so many nerves are going through that, the neck area. So Horner syndrome, recurrent laryngeal nerve palsy, paralysis of 7th, 11th, and 12th cranial nerves due to traction of the nerves during surgery, but it is generally reversible. 2 points regarding emergence delirium. Now, there is post-operative disorientation and agitation with so many factors. And it may be pain, hypoxia, hypotension, hypocarbia, and so on. But emergence delirium is the hyperactive psychomotor and aberrant cognitive behaviors following general anesthesia. So it's a combination of disturbance in behavior and cognition. And agitation. Emergence agitation is a part of delirium, not otherwise. So desflurane, sevoflurane, rapid emergence, age less than 5 years, post-op pain, surgical procedures around head and neck. They are the causes for delirium. Now there are various scales. Pediatric anesthesia emergence delirium scale, PED scale, which has 5 points: eye contact, purposeful movement, awareness surroundings, restlessness, and inconsolability. These all are not there. There would not be any eye contact, no purposeful movement, no awareness surrounding. Baby would be restless and inconsolability. So maximum score of 20, and more than 12 means emergence delirium. There are other scales also, Crevero scale and Vacha scale, but they are simply the agitation scales. So they corresponds to the assessment like in Ramsay's sedation scale. So they are very simple to perform, but real delirium judgment score is the pediatric anesthesia emergence delirium scale. Now for that, propofol, fentanyl, or midazolam can be given to reduce the emergence delirium. And anticipating difficult airway problems in children and having a structured approach to manage the airway prevent the serious consequences of perioperative hypoxia. Thank you.